everybody. I'm here with Dr. Michael Levy. Hi, Doctor. Welcome to our second MOGCast series entitled The Latest from the MOG Initiative. Today, we are speaking with Dr. Michael Levy from Massachusetts General Hospital. My name is Julia Leffler, Executive Director and co-founder of the MOG Project. The MOG Project is a US-based nonprofit organization devoted to raising awareness, advancing research, and providing support and advocacy for the MOG-AD community in hopes of finding a cure. We would like to thank Dr. Levy and the MOG Project members for their contributions to this MOGcast. This MOGcast is being recorded and will be available on our website, Facebook page, and YouTube channel. If you want to submit questions, please feel free to do so by commenting on our Facebook Live video. We will be answering community questions time permitting, so any questions left over will be answered in a follow-up MOG blog or future podcasts, so stay tuned. Dr. Michael Levy is an associate professor of neurology who was recruited to lead the research unit in the new division of neuroimmunology at the Massachusetts General Hospital. His mission is to build a combined clinical and research neuroimmunology program to develop therapies for patients with autoimmune diseases of the central nervous system. Dr. Levy moved from Baltimore, Maryland, where he was on the faculty at Johns Hopkins University since 2009 and director of the Neuromyelitis Optica Clinic. Clinically, Dr. Levy specializes in taking care of children and adults with rare neuroimmunological diseases, including neuromyelitis optica, transverse myelitis, MOG antibody disease, and acute disseminated encephalomyelitis. In addition to 4 monthly clinics, Dr. Levy is the principal investigator on several clinical studies and drug trials for these conditions. We're here today to talk about Dr. Levy's laboratory work specifically related to the work he does in MOG-AD. Welcome, Dr. Levy. We're thrilled to have you here with us today.
Thank you, Julie.
Well, I want to jump right into the first question. And these questions are about the clinical trials. So I'm not sure if you're aware, but this new clinical trial that's come out is basically all the buzz in the MOG community. Can you tell us a little bit about that, the history of the drug and what it's currently used for and how it conceptually is going to work in MOG-AD?
Sure. Well, the way this came about is because of our interest in using IVIG for MOG, which we recognized fairly early on as a really good option in the sense that patients would go into remission fairly quickly. But it was very logistically difficult. All the IVs and the headaches and insurance coverage, dosing strategies, it was all logistically difficult, but biologically effective. So we wanted to see if we can kind of shortcut the process, go directly to the mechanism that IVIG was acting on, and see if we could get rid of all the logistical problems, but still get that biological effect that we want. And for a lot of diseases for which IVIG is useful, this shortcut approach is being developed, including myasthenia gravis, chronic inflammatory demyelinating polyneuropathy, or CIDP, Guillain-Barré disease, many others for which IVIG is being used. They're now developing this other drug that'll shortcut all of those problems and go directly to the problem, activating the biological pathway that IVIG uses and just making it a lot easier, like in a patch form or a subcutaneous injection, things like that. So I thought this would be a great idea for MOG. I contacted 2 companies that were developing this product, and I told them about MOG antibody disease, and I just got kind of some blank looks. And I just didn't stop there. I went on and I called the next company on the list, and that was UCB in London. And I talked to a high up person there who thought this was particularly interesting and said, why don't you come to London, talk to the team, see if you can convince them. So that was probably in 2017, maybe 2018. I can't remember now, it was a while ago. But I went out there, we had great meetings. I think I got some excitement around it. And fast forward now, we're 3 or 4 years later, and we're finally getting the trial off the ground. So that's the long backstory to how this finally got started. But I've been involved the whole way along, and I'm just really excited to finally get this going. You're muted, Julia. I know you haven't used Zoom that much, but you know.
I know that's all we do. You'd think I'd be able to do that. I appreciate that response. I mean, that's amazing because I definitely remember you talking about it early on, you mentioning it, but I didn't realize
I've been
it.
waiting for a long time for this.
Yeah, very exciting. So I guess I would like to know, it's called rosanolixizumab or Rosamab, right? So we wanted to know how that's created, and is it donor-based like IVIG or created in a different way?
It's created in a different way. It's synthetic, but it is an antibody. And just like rituximab is an antibody, and all the biologicals that are used for neuromyelitis optica, they're all antibodies. Rosanolixizumab is just another antibody. In this case, I believe it's produced in cells and then purified. So cells in a dish and then purified. So it's not raised in animals. That's how we used to make them. But now we just use cells in a dish. We can get the same product without harming any animals. But the idea is that this antibody, this rosanolixizumab antibody, it is trying to do the same thing that IVIG does. So the benefit that we see with IVIG is the idea that you're diluting all of your antibodies with donor antibody. So you collect in one bottle of IVIG, you get between 10,000 and 50,000 people's antibodies, all concentrated into one bottle. And when you infuse that into a person, you're basically just totally diluting the patient's own antibodies. And then as the body gets all these donor antibodies, it recycles all of it back to a normal level. But most of the patient's antibodies are now gone. They're recycled and destroyed, and the patient now has antibodies from other people. Eventually, though, the patient will make all of their own antibodies back, and probably at the end of 4 or 5 weeks or so, it's back to how it was before. So that's why IVIG has to be dosed monthly. The way rosanolixizumab works is a little bit different. Instead of diluting antibodies, it just triggers the recycling of your own antibodies. So what happens is you get this rosanolixizumab drug, and your antibody levels drop by 70% in a day. And then they all get recycled, and your body will just start making more again. So it's, instead of diluting the antibody, you're just reducing the antibodies that the patient's making.
That's pretty interesting. You know, I guess, so that's every antibody that you have then, correct?
Correct, not just MOG, but it is all of the antibodies. And that has a quieting effect on the immune system.
Wow, okay. That's interesting. I think a lot of people would want to know that distinction. So I'm glad that you said that. So as far as the trial, could you tell us a little bit about eligibility? For instance, who are you looking for? What criteria? What eliminates people, and so on?
Well, this is a preventive study. We're trying to prevent the next attack of MOG. So you have to, there are a lot of MOG people who never have a second attack. We obviously don't want to include those patients in the trial because we're trying to prevent the next attack, and we want to try to impact the disease process. So we're only enrolling people who've proven that they have relapsing MOG. So that's at least 2 attacks. And then one of those attacks has to be in the past year, because we don't want people who've been in long remissions, because if we're trying to prevent attack in the next year or 2, we don't want people who've been in a prolonged remission, because that could just be the chance of the disease just not relapsing again. So you have to have 2 attacks in your life, and 1 has to be in the past year. You have to test positive for the MOG antibody, and you have to be an adult for this study. I think we're going to get into kids later on, but I really did push for enrollment of kids in this study. The problem is that you have to redo all the dosing if you're going to enroll kids. You can't just give them one dose, because kids are not just small humans, but they also metabolize antibodies differently. And so you have to do all of the antibody dosing tests to be able to enroll kids. And I think the compromise we got to was, well, perhaps we'll enroll large kids, 14, 15-year-olds at least, who are 40 or 45 kilograms body weight, so that they metabolize and handle the drug in much the same way as grown-ups do. Now, we don't have that commitment yet from the company, so right now we're just going to be doing adults, but we're hoping to add on kids after we demonstrate that adults respond safely.
Okay, so just a quick follow-up. So I've seen some comments from people on this that said that you would be eliminated if you've had an attack within 6 months. That's not true, correct?
It's not true. We don't want people who are still in the midst of their most recent attack. We want them to be in remission. We want that last attack to be treated and then to be stabilized. I don't remember what the time is from the onset of that last attack. I believe it's 3 months, but I could be even 1 month. I can't remember, but basically that last relapse has to be done.
Okay, so we would encourage people to, at least inquire.
Definitely. You don't want to wait too long, because if you're out of that 1 year time window, then you're not eligible anymore.
Okay, thank you for that. So this is obviously going to put some, something to do in everybody's daily lives. And so could you tell us about how their daily lives are going to be affected as far as time commitment, the type of treatment delivery, any clinical visitation or anything else like that goes?
We're trying to make it convenient, and the pandemic has actually helped make it more convenient in that regard, because we've convinced the company that most of the visits should be done at home over Zoom, and only some of the visits in person. So the first 4 visits are once per week, and those have to be done in person. There's lots of testing that has to be done, including all kinds of different clinical assessments and blood draws. And then we give the first 2 or 3 doses in person, where we show you how to apply the patch. It goes on the arm or the leg. And we want to be there while that happens and just make sure that you don't have an allergic reaction or something like that. Then after the first 4 weeks, then you can go home. And from then on, for the next 3 months, you'll just take the patch once every week at home. And I think, we're going to have this set up on Zoom so that you can show us where you put the patch and that you responded okay and so on. And the patch stays on for about 15 minutes. And then afterwards, you just take the patch off, and there'll be some observation time. And then after 3 months, and you come in once every 3 months for an assessment, blood draws, urinalysis, things like that. So we're trying to make it as convenient as possible.
Okay, so it sounds like you probably need to live near the clinic, since it's every 3 months, unless you wanted to travel up there, correct?
You could pick a clinic site. There'll be 20 different countries and something about 50 different sites available. So Boston will be a site. We're hoping to open sites all across the North America and in Europe. So hopefully it won't be too far or inaccessible to people. Obviously, they're going to pick population centers. If you don't live in a city, you might have to travel to the city. Mm-hmm. But then after those first 4 weeks, so if you're going to enroll in Boston, you have to kind of be in Boston for those first 4 weeks. But then after that, then you can just come once every 3 months for just a 1-day visit.
Okay. That's good to know. So we're basically getting messages from all over about wanting to participate in this clinical trial. Have the locations that you're talking about been determined yet? And is there a list somewhere where people can go and see that yet?
Not yet. We've reached out to all the sites. They all have to go through a contract process to make sure that the institution is supportive of the trial and that the principal investigator at each site is aware of how everything works. But we did have our first investigator meeting. It was about 2 weeks ago or so for both the Eastern Hemisphere and the Western Hemisphere. On the Western side, was at a reasonable hour, and I addressed everyone and explained how this all works. And I think there was reasonable excitement, and I believe there were about 20 or so investigators. I remember specifically people in Colorado, in California, and other places. And then we also had a similar investigator meeting for Asia, and I had to get up at 2:30 in the morning to give that address, which was fine because, you know, the hours are 12 apart. So, but we had a nice turnout there as well from representative countries from all over the East. And so I'm hopeful that there'll be a lot of options, but they have not yet been publicized.
Well, we'll certainly look forward to that. So I want to just ask a little question that's been, I think, asked of us, and I think it's in the literature, but I want you to kind of expand on it a little bit. So what if somebody joins the clinical trial and, you know, they're going on with whether they have the medicine or not, and they relapse? What happens then?
The whole trial is designed to prevent relapses, but there is a placebo arm. So the enrollment will include people. It's randomized. I don't get to pick. You don't get to pick. No one gets to pick. It's randomized where you'll end up. But people are only allowed to have one relapse in the study. And once you have what's called an adjudicated relapse, meaning it can't just be a relapse that we think happened. It has to meet all the criteria. There might be MRI criteria imposed, or OCT or ophthalmological exam, or some other criteria. If you meet that criteria and it's called a relapse, then you're done with the randomized portion of the study. You're going to get treated. Everyone usually starts with steroids, but it's site specific. So your doctor gets to pick for you. And if they use IVIG, like we use IVIG heavily, that's an option, or plasma exchange, or basically wherever in the world you are, your local standards of care will apply. And after you're treated, then you're guaranteed the actual drug in the patch from then on until the end of the study. So if you were in the placebo arm, you won't know, right? When you relapse, you won't know if you failed the actual drug or if you were in the placebo arm. But either way, from then on, you get guaranteed medication in the patch, and you can use it for as long as you want. You don't have to accept that. You can then go back to IVIG or some other approach that you were happier with. But if you want that definite drug from then on, then you'll get that until the trial is done and the local agencies have approved the drug in your country.
I see. So that's pretty comforting, especially for people that are worried about being on the placebo and getting a relapse. And is that true if you're, you know, they know at the time that you're actually on the drug, don't they? Or so if you were on the drug and you relapsed, would that be the same thing? You would be given the option to just continue, and you definitely get the drug, of course, like still, or would they, you know, allow you to get out of the clinical trial?
It's tricky because if I peek into the randomization book to see which arm you were in when you relapsed, it biases the whole trial. It distorts the way we evaluate patients, and the FDA doesn't know how to evaluate the data as a result. So this is really importantly a double-blind study. You're blinded, everybody's blinded. The only person who's not blinded is a pharmacist who has no idea what this trial is about and is just there to randomize things. But everything has to be done in a double-blind manner in order to really minimize any bias that comes out of knowing what you're getting and what you're not getting. That's really the best way that the FDA can evaluate the results, or your country's regulatory agency can really evaluate the science and determine if the drug is beneficial or not.
Okay, wow, that was a really good peek under the hood. And I think that clears up really how and why this has to work. So thank you for that. My next question is just kind of going back to, just the comparison with IV, and subcutaneous IG. Those don't suppress the immune system. Does Rozumab's mechanism really cause immune system suppression? It sounded a little bit like you said it did, but is this suppression similar to other treatments that we take for MOG-AD that are not IV, IG, and subcutaneous IG?
It's very similar to plasma exchange in the sense that you're just removing antibody and then making it back again. You would imagine plasma exchange would be immune suppressive if given on a regular basis, but we just haven't observed that. And it may be that we're not taking out enough antibody or the patient's producing enough antibody regardless. And the same is true with rozanolixizumab. You would think taking out 70% of your antibody in one day would make you suddenly vulnerable to all kinds of infections. But in fact, that doesn't happen, and their side effect profile doesn't show any increased risk of infection. So it does make sense in terms of rational explanation of how this drug works, that you would think that it should be immune suppressive, but it doesn't seem to work that way. Now with IVIG, you also get an immune calming effect. When you flood your system with antibodies, there is a negative feedback loop. So the immune system goes, whoa, 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 hang on, we got to redo this. And everything just kind of calms down and dies down for a second while your antibodies are recycled. And that's not really immune suppressive either. People on IVIG don't get weird infections, and they're not more likely to get common infections. So again, rationally, when you're talking about these medications, you can understand that your immune system does get either activated or calmed down, but not to any degree that you would notice, and not to any degree that you would get any infections as a result.
Okay, so subcutaneous IG is more of an even distribution over the course of a month. Does it have that effect as well, or is that one that isn't quite working like IVIG or this Rozumab?
Subcutaneous IG is a easier delivery of the same amount of antibody. You just put it under the skin, it forms a little pooch under your skin, and then it dissolves over the course of 48 hours into the body. And for a lot of people, it's easier to do one injection like that every week than to do 4 times that amount intravenously that might be divided over 2, 3, or 4 days. There's never been a direct comparison about which one is more or less effective or immune suppressive. The idea is that whether you're getting it subcutaneously or intravenously, you're getting a certain amount of antibody, enough to trigger recycling of antibodies. Mm-hmm. and that calming effect. You get that whether you use subcutaneous or IV.
Okay, so that's actually very helpful. Thanks. So could you just tell us a little bit about the possible side effects of Rozumab, and what are some of the possible adverse effects that people may present with during or after treatment?
The side effect, the number one side effect, and I'm not sure why, is headache. It's true with almost every biological. That's true with Alexion's drug that was approved for neuromyelitis optica called eculizumab. It's true in almost every disease in which rozanolixizumab has been tested, and many other. Headache is number one on almost every side effect profile for biological drugs. And someone did an interesting study looking at the reason why. And the best explanation is that when people are enrolled in these studies, they tend to not stay hydrated on the day of the infusion. they're nervous or excited or whatever, and they don't have their normal cup of coffee or breakfast or whatever, and they come in and in the dehydration process tends to trigger a headache. That is the best explanation we can come up with, because it's not like these drugs get into the central nervous system. They really don't. They remain outside in the periphery, in the blood, in the lymph nodes, and everywhere else. So it doesn't really make sense that headache should be number one in almost all of these drug trials, but it is. And so that's true with this drug as well. And then upper respiratory infections, urinary tract infections, the things that people commonly get anyway are kind of number 2 and 3 on the list.
Okay, thank you. Well, let's say this goes through these clinical trials. What kind of timeline should patients expect for this to reach FDA approval in the best and the worst case? I know it's not an exact number.
Yeah, this trial is expected to go through 2024 at least. And then it would require some analysis and FDA filings and things like that. So maybe 2025, I think, is best case scenario.
Mm-hmm. Okay, that's good to hear. That's not too far away.
Not anymore. I mean, it's already end of 2021. So
amazing. So with the recent Soliris approval for aquaporin 4 NMOSD and the cost of it being so high, what are your expectations or their expectations for the cost of this?
They never share that with me. It's always a fear of mine that a drug that I'm helping to get approved is going to be priced out of range of my patients, and I'm not happy about that, but I already know that these companies will not share that type of information with me. So even if I ask, they're not going to say, and most of them don't even know. So the team that's helping me to develop this at UCB, they're not even going to be involved in the pricing. It's going to be a whole different team of commercial people who price this out and figured out how to make a return on investment and still be within guidelines of payers, insurance companies, and Medicare and things like that. So I'm worried that it will be priced high, and I'm always going to continue to put pressure on these companies to just make it accessible to our patients. So if they're underinsured or uninsured, to have a free drug program, at least for those patients.
Oh, that's good to know. Thank you. So we've heard and read about other studies and new upcoming research with satralizumab and tocilizumab being used for MOG-AD. Are these the drugs for upcoming clinical trials and something you are familiar with? And if so, how do they help with MOG-AD?
So these are studies. I'm under a confidentiality agreement to not talk about them until they're public, because these companies don't want stocks being traded around on data that's not publicly available to everyone. And so I can't say too much about satralizumab, but tocilizumab, which is the parent compound, the older version of satralizumab, has been studied in academic centers. And we contributed our tocilizumab patients to a larger study group where we found that whether it's injected under the skin or infused intravenously, tocilizumab does seem to help in MOG antibody disease. And so it wouldn't be surprising that a company like Genentech, which manufactures both of those drugs, that they may take notice of that, and they may want to investigate that further.
I see. So are either of these drugs that you know being used in any pediatric patients, or is it just still only being used in adults?
I don't think there's any reason why we couldn't use them in pediatric patients. Tocilizumab has pharmacokinetic data in children. In the rheumatology literature, it's in fact approved for a juvenile rheumatoid arthritis in the United States. So we do know what its pharmacokinetics are. So if we wanted to dose it in children, we could. I wouldn't say it's among the most popular options, I would say that IVIG is still the most available and widely used, followed by a combination of prednisone, prednisolone, with azathioprine or mycophenolate. And then there's still some people who are on B-cell therapies like rituximab that have some benefit from that. And so tocilizumab is probably right after that, number 3 or 4 on the list.
I see. So we have a community question, and just to verify, they are asking if this, clinical trial for rozumab is in reference to the trial that was discussed at the sRNA symposium a few weeks ago.
I can't remember what I had for breakfast. I really don't remember what I talked about a few weeks ago, but it is the only trial that's been launched in MOG. So if we talked about a trial that was just recently launched at the sRNA, that would probably be this one.
Yeah, I believe you're correct on that. Thank you. So I kind of want to switch the conversation up a little bit, just to talk about other progress made in the MOG-AD world. So as you know, proposals have been put into the World Health Organization and the CDC by the MOG Project with help of Dr. John Santora and UCB. And, we wanted to change the classification of MOG-AD to be regarded as a separate disorder. This is going to allow doctors to give patients a specific diagnosis code for insurance purposes, at least in the US. Can you talk a little bit about how, if, and when this is approved, that your research, especially in the MOG Initiative, will be affected, and why would this be a good thing?
Those diagnosis codes are mostly used by insurance companies. And so if we have a diagnosis code for MOG, then an insurance company could say, okay, if that's the diagnosis code, here are the drugs that we'll pay for. And we're hoping that any new drug that's approved by the FDA will make it onto the insurance list, and it should be matched to that diagnosis code. Currently for MOG, people are given codes of MS, they're giving codes for neuromyelitis optica or acute disseminated encephalomyelitis or transverse myelitis. And so MOG patients have all kinds of billing codes, none of which will probably be tagged to any new drugs. So when these companies are developing drugs, they really want to know that there's going to be a diagnosis code for them, so that insurance companies know how to match the drug to the diagnosis code. So that should come out, I would guess, probably in the next year or so. And I hope it'll be widely adopted. It takes some time to transition our thinking. For example, I know MS code is G35.0, and there was a diagnosis code before that. And so these things take a little bit of time to transition, but the electronic software should make that easier for us. And I think as soon as there is a diagnosis code for MOG, most people will adopt it.
That sounds great. I think that a lot of people are looking forward to that. Switching it up a little bit, could you please tell us a little bit about any plans to create a MOG-AD biorepository? Why would this be different than, say, blood collections made at various research laboratories like the Mayo Clinic or Johns Hopkins, where many of us have donated tubes of blood, probably yearly?
Yeah, these biorepositories are so important because for a disease like MOG, we can really try to understand what parts of the immune system are active or disrupted. And we really can't do that without these biosamples. Every center has their own. We have a biorepository at our center. And I know Johns Hopkins has one, and as you said, Mayo. And Mayo also has the advantage that they keep extra serum that we send them for clinical testing. And so that really helps them in their research as well. Now, the best case scenario is when we all contribute together in a systematic way so that the serum or cells that I'm studying are drawn and collected and preserved the same way at Mayo and at Hopkins and at other places, so that when we share data or compare data, we're comparing apples to apples. Now, that kind of cooperation is not super easy. It is somewhat expensive as well, but some companies have stepped up. Kathy Jackson, for example, is a foundation in NMO space that put together this huge biorepository, and it's yielded dozens of papers in different studies already. So it really enables good research that can only be done in a team setting rather than Mayo having to collect 50 samples over 10 years and us having to collect 50 samples over 10 years. By combining our resources and standardizing it across different centers, we can really make progress a lot faster.
Excellent. So if you are planning on putting this together, when would you expect to have it up and running?
We don't have a funding source yet. We don't have a sponsor. We don't have a company that's really invested in this yet. We're applying for government grants to host a collaboration. Initially, me and my colleague at the Mayo Clinic, Owen Flanagan, we're going to put in for a small grant. It's a $2 million grant funded by the FDA, who's currently evaluating all these different trials for MOG. And they must have a lot of questions, as do we, about how long do people need to be treated? What is the current standard of care? What is this monophasic form of MOG? All these questions that can be answered if we're collecting data and samples in a systematic way together. So we're hoping the FDA approves our grant, and that'll be just the start. It's just 2 centers, but then we can expand from there. And it is expensive. If you ask the Kathy Jackson Foundation how much they spent on their biorepository, I know the numbers, I don't want to embarrass anyone. It was a lot of money. So these things just are very expensive. So we're going to have to do it probably in piecemeal.
I see. That does sound like a big endeavor. So, if somebody wanted to participate in that biorepository, how would that work? And would you be collecting samples just from adults or pediatric patients?
In the proposal we submitted to the FDA, we're trying to recruit patients from all over the United States to allow for remote recruitment, again over Zoom, where we would send a kit for blood draws and other samples, saliva and whatever else we need. And then we would try to conduct an examination through Zoom in a standardized way. And in addition to that, try to collect more clinical data using things like your phone, which is usually on you or a wearable device, so that we can collect things like vital signs and how much movement you make and things like that, so that we can really keep track of our patients' daily function, even when they're far away from Boston or Rochester, Minnesota.
Mm-hmm.
So, we haven't been approved. I don't want anyone to start asking me to enroll anybody, because this is not even yet on the FDA's radar. This is still in the grant preparation process.
Okay, I see. We'll make sure that we put that on hold in our minds for a little bit. So just a quick question about, I guess, does research in the area of MOG-AD impact research in MS? And if so, how or what other demyelinating diseases does this research help?
Well, it's from the start, MOG has always been thought to be a variant of multiple sclerosis. The MOG mouse model that was developed in the 80s and 90s was thought to be MS, and a lot of MS drugs that worked in the MOG mouse failed in human trials with MS, because MS is not MOG and MOG is its own thing. Now, MOG in a mouse is not exactly the same as MOG in a person, so you can't just immediately translate that. But there is a lot of interest in MOG because there is an immunological target. We don't know the target in MS. We think there's one, but we don't know if there is one, and we don't know what it is. But if there is one in MS, then we can take everything we're doing in MOG in terms of trying to calm the immune system down and even to re-educate it, and then we could apply it to MS. So it's what we call a proof of concept disease model, where we know the target in MOG. We're going to try to target the exact problem. And then if we can fix it in MOG, and we can fix it in aquaporin 4 NMO, then when we find the target in MS, then maybe we'd be able to fix it in MS and other autoimmune diseases. Myasthenia gravis, we know the target, but in lupus we don't, Sjogren's we don't, lots of other autoimmune diseases we don't, but these are proof of concept studies that we could then apply when those targets are discovered.
Ah, interesting. I do have a clarification from the community. They're asking for going back to the clinical trial. Does this pertain to NMO, they ask, and does this include ADEM? And so just give a quick clarification there.
It does include ADEM if it's MOG positive. Somewhere between 40 and 50% of ADEM cases are MOG antibody positive. And so that it would include those cases as well. And NMO, you asked about NMO. If NMO is MOG positive, it would be included. So it doesn't necessarily matter so much whether you have optic neuritis, transverse myelitis, or both, or ADEM. It doesn't, the attacks that occur are less important than the underlying immunological process that we're targeting. And if there is a MOG antibody component to your attacks, that's really the important part.
I see. That's good. That's a good clarification. So we have about a little over 10 minutes left. So I wanted to switch over and just discuss the future of your research for the MOG Initiative. And, really what's going on now. Could you tell us what research has been happening at the NMO Clinic and Research Laboratory concerning MOG-AD, and what areas of research do you consider the most potentially impactful?
We're really excited about identifying the precise problem in MOG, to identify which cells are reacting to MOG and why they're reacting that way, and then to see if we could re-educate those cells so that they don't attack. For whatever reason, in MOG patients, their immune system is treating MOG like a foreign protein. They're mounting an immunity to it as if it's a foreign protein, like a viral protein or something like that, but it's not. It's a self protein. And what we're really trying to do in the lab is to re-educate the immune system, to take it from a foreign protein to back to a self protein, to just switch that response off. And we're doing that in mice first, and we're hoping to translate it to people. And the MOG disease has caught the attention of companies. So there are companies, at least 3 out there, that are also excited about this approach. And they're all working in these mouse models of MOG to re-educate the mouse immune system. Now, it's not, as I said, it's not that easy to just translate that into a human study. You need to understand the basis of the MOG response in mice and how that works in people. And so we're kind of doing both. We have a mouse group and we have a human group. And then eventually we're hoping to synthesize the two. And I'll say that we're working with all 3 companies to do this. I don't have a horse in this race. I just want to solve this problem. I don't care who makes all the money at the end. I really believe that this approach is really the one that's going to fix the underlying problem. And so that's why we're excited about it.
Oh, believe me, we all are. That would be incredible. So I want to ask, are there any greater hopes of regenerating the spinal cord, brain lesions, or optic nerve? And would this help all types of demyelinating diseases, including MS?
Well, MOG is one of those really interesting conditions. Early on, after people have even a severe attack, early in the course of the disease, most MOG lesions heal fairly well. There's some residual problems, and I know several patients who have persistent problems, but compared to almost every other demyelinating condition like multiple sclerosis or neuromyelitis optica, MOG patients heal the best. And they routinely have the better outcome compared to MS and certainly compared to NMO. So there's something about MOG that allows remyelination, even of long, horrible looking lesions in the brain and the spinal cord, and sometimes in the optic nerve. And we're wondering if we can learn from that. What if we could take the MOG healing process and apply that to MS? Would MS patients then do better, or to NMO? So I know it sounds a little odd, right? That you're asking about remyelinating MOG patients, but I'm actually thinking about learning the biological process that allows MOG patients to heal so well, and then applying it to diseases that don't heal so well. For all of these diseases, we're also working on a stem cell approach. We've partnered with a company called Blue Rock. They're based in Boston. They have a stem cell product that we're testing in optic neuritis. So these rats get optic neuritis. We use rats because they have big optic nerves. They get optic neuritis, and then we surgically transplant without cutting any bone. We can get directly to the optic nerve and transplant these stem cells. And we're really hoping to regenerate the optic nerve after optic neuritis. And so that could potentially be applied to any condition, whether it's MOG or NMO or MS or optic neuritis from any other cause.
Wow, that would be amazing, because, there's some people that even with MOG that have just 2 attacks and have devastating results, and some people that have multiple attacks like myself and recover almost completely. So, it might even be a mystery solved there just to capture that. So are there any potential for targeting the MOG antibody specifically in treatments?
We don't know if the MOG antibodies should be targeted. We don't know that it's that harmful. Maybe it's just a product of the immune response, and really it's the immune response that's harmful. So we're not quite sure what to make of the MOG antibody. There's a lot of interest in that area. If you take the MOG antibody in the mouse model and you transfer it, by itself, it doesn't cause any harm. So, but that again doesn't always translate to a human person, and we're not going to do a human study like that. So we just don't know the answer completely yet, but it's something that we're looking at, trying to understand better.
Interesting. So I want to kind of have you comment on your recent study in nutrition. Did you come to any conclusions about the link between any nutritional changes that you might want to do and MOG-AD?
The conclusion we came to is that diet studies are difficult. They're difficult to do. You have to remember what you've eaten in the past 2 weeks, and I can't remember what I had for breakfast, for example. So it's a really hard type of study to do. And we did not find any really strong associations, no. One of our experts is thinking about doing an elimination study where we pick one thing that we want to eliminate from the diet and then follow those group of patients prospectively to see if it makes a difference, either in their activity, disease activity, like how many relapses they have in the future, or in their daily function. Those are just really hard to do. There's a lot of gluten, for example, in foods that you don't even know have gluten, and it's really hard to ask people to make sure that every single thing that they eat, even in restaurants, is gluten-free. So diet studies are just notoriously difficult to do, not just in MOG, but everywhere. But we have people interested in doing it, so I'm going to continue to support them, and we'll see where we can get with that.
Okay, thank you. I want to grab a community question. this person says, so those that get on the trial and have success, will they have to stop the medication until it gets cleared by FDA, or would they be able to continue the drug until FDA cleared? That's assuming I assume that's if the drug seems to be helping them.
If the drug proves helpful, patients get to stay on it until the FDA approves and they have a chance to transition to insurance care, insurance covered drug.
Oh, wow.
That is a promise from the company for participating.
Wow, that's actually a very good thing. That was a great question. It's a good thing to know. I want to ask another question that we kind of have a couple minutes here, that seems to be asked all the time. How can patients get away from using steroids for their MOG-AD, especially in the acute stage? Is there any research besides, in this acute stage, going on to replace those medicines, or I guess the steroids used for the acute attack?
Steroids work. That's just the truth about it. Is MOG patients with a relapse, you start treating them with high dose steroids and the relapse starts to go away. So it's really hard to minimize that fact because steroids are widely available. They're easy to get. Almost every emergency room has them. People aren't allergic to it. I mean, it's really very effective. The problem with steroids is, of course, coming off of them. You can't, if you could just stay on high dose steroids every day, your MOG would disappear. But steroids have many other metabolic effects, so many side effects, I can't even name them, including weight gain, blood pressure, just so many hormonal effects, everything else. And so the challenge is treating them with steroids. If you're going to do that, the challenge is then taking them off of the steroids. If you do it too quickly, it'll trigger a relapse of MOG. So you can't do it quickly. You have to do it slowly over a period of, we don't know, 2 or 3 months, maybe, sometimes slower, sometimes maybe a little faster. Because of this steroid problem, this biological dependence on steroids and all the side effects from it, I've transitioned to using IVIG as much as I can, even in the acute stage. It's hard to get IVIG in any setting, including inpatient, but it's something I've been pushing for because of that that ability to defer having to use steroids. So that's what I've been doing. But what we really need are better trials in the acute stage. We know plasma exchange works. We think IVIG works, and we know steroids work.
That's great to hear, that it is being looked at. It seems to be a problem for a lot of people. One more question about MRIs, we wanted to know if a patient thinks they're having an acute attack and they have a negative MRI, yet they seem to have clinical findings. Is there any research going on better imaging to detect disease activity?
Oh, that's a great question. There's a lot of disease activity that just doesn't show up on MRI because it's not an anatomical activity. So MRI just shows you a picture of what the brain and optic nerve and spinal cord look like, but you can't see anything moving and happening on an MRI. Same with an optical coherence tomography picture of the back of the eye, the retina. It's a snapshot. It's a one-time view, but you can't see anything happening. There are other studies, there are other modalities to look at activity, but within the central nervous system, it's hard to access that activity. For example, if there's something going on in the spinal fluid, you'd have to do a lumbar puncture just to get that. And then you're only getting a snapshot in time of when you got the lumbar puncture. It's a very difficult thing to do. So we don't have any great modalities at this moment, but I can tell you that in mice, for example, in MOG mouse models in mice, there is a lot of disease activity that occurs outside of attacks. So even in between attacks in mice, there's a lot of stuff going on, for example, in the spinal fluid that may explain some of their odd behaviors that could be considered more psychological, like anxiety and shivering and things like not being social. And if you translate that to people, maybe that translates to anxiety, depression, and other behavioral things that are going on in people. But those are big stretches, and I don't want to make any major conclusions like that, but it is something that we think could be going on even between attacks, yes.
Wow. Well, that is really, I'm sure it's very difficult, but we hope that there's some, more progress made in that area. I just have one question because we've run out of time, and it's been a wonderful discussion. So this community question is asked, how can I participate in the clinical trial when it starts, just so everybody knows?
You just go to clinicaltrials.gov. You look up rozimab, rosaneluxizumab. You can even look up MOG, and it should be listed there. And when you click on that link, all of the sites, all of the actively participating sites will be at the bottom. And ours would be first because I'm proud to be the first site. And if you don't see anything near you, you can just email me. My email will be on that clinicaltrials.gov site, and I'll be able to tell you where to go if there is a site opening up in the near future, for example.
Okay, and we will post in the event page that link, as well as some other links, especially to your MOG initiative. I just want to stress how, everything we talked about, donations from the community are so important. So we'll make sure that, people can send money directly to the MOG initiative, either through our website, we have a special link there, or it'll be directly on the event page there. So
Much appreciated.
oh, thank you for everything you do. So, I'd like everyone to just give a round of applause at home for Dr. Levy, and we'd like to thank him for his time and commitment to the MOG community. So if you'd like to check out the page on our website dedicated to the work that's being done for MOG-AD at the NMO Clinic and Research Laboratory at Mass General Hospital, please visit our website at mogproject.org and look under the From Our Medical Advisors menu option, then select the MOG Initiative. And so there's a nice page there with some videos that Dr. Levy so graciously made. So if you scroll to the bottom of the page, there are suggestions on how to participate in the MOG Initiative, including a link to directly donate to research. So you can also go directly to the page for the MOG Initiative at mogresearch.org. And like I said, we'll have some of these links in the event page after. So Dr. Levy, thanks for this great discussion. I hope you have a really good afternoon, and we'll look forward to following. You take care.
Take care. Bye-bye.
Okay, bye-bye.